Dr. Dalia. For a question from the floor,
Thank you very much, Dr. Dalia. Dr. Amir, please join us. Dr. Ali, if you have online questions, you can start. Well, we're waiting for questions here at the audience.
No question. Go ahead.
Any questions?
Can I start with a question for my colleague,
Sure.
Dr. Amir? Dr. Amir, you talked about congenital hypothyroidism now, and the treatment and some tips about treatment. Now, I was traditionally trained that we have to be keeping the TSH range strictly normal, i.e. we don't follow the normal TSH level up to 5, this is normal, strictly to keep it between 0.5 and 2. And to keep the free T4, we be comfortable with a little bit of elevated T4. So what is your take on this, now that we have more evidence that these kids may be overtreated and hyperthyroidism and overtreatment also might affect the brain? So I'd like to take it.
Sure. Yeah, thank you very much for the question. Excellent question. Actually, a short answer to this, if we deal with central hypothyroidism, which is a rare entity, usually we focus on T4 and we try to get it in the higher side, because you know that we have fluctuations of the level of hormones during the day, and during the test you only have a snapshot of one time of the day. So to ensure a good neurodevelopmental outcome, you need to have this T4 usually above 15 towards 20. And for the primary type of hypothyroidism, obviously I mentioned one of the complications of craniosynostosis, but as I mentioned, neurodevelopmental outcomes should be prioritized. I would be happy with levels of TSH as you mentioned, and but provided that the T4 is not repeatedly detected around 10 or low, this would indicate inadequate thyroxine or thyroxination of the brain. I think clinicians may have different approaches, but this is how I deal with it.
Thank you, Doctor.
Thank you. Any questions? Dr. Abduraouf, any question? No? Okay. Dr. Ali, any questions online? I can ask the last question, since I'm the chairman with Dr. Ali. There are different ways of measuring the thyroid test for pediatrics, and you showed the States is different from Europe and many other countries. Which one have the best sensitivity and specificity? Is it all cost effective? This is how they're differing, why they're doing this way or that way?
You mean for the thyroid?
For the screening. For
the screening, yeah. Yeah, it's a good question, actually. I mentioned the only advantage of a primary T4 test with a backup of TSH is not to miss the central type of hypothyroidism. However, TSH has got very good, approach and the screening, it's very useful actually, and it has some false negative, but obviously during screening you focus on not to miss, and obviously sensitivity is more important than specificity. So most of the countries use TSH approach with a backup of T4 if you have a suspicion. But obviously the T4 one may be useful for the central, but most of these children present with any central problems or some signs that indicate they may need to be checked for the T4 anyway.
Thank you. Thank you. If there's no questions, I'd like to thank all the...
Just one question, please. Just I want to thank Prof. Haneke. Do you give radioactive iodine for all children with the papillary thyroid carcinoma, or depend on the risk, low risk, high risk, intermediate risk? Because one of the recommendations, do you hear me? I found that you write for all after total thyroidectomy. So you'll give all radioactive iodine?
Yes. Thank you for the question. It's an important discussion. So now in the European recommendation, we indeed have recommended to give radioactive iodine to all children after total thyroidectomy, because in many of the children there are small metastases, and you can use also your thyroglobulin as follow-up marker when radioactive iodine has been given. However, I do feel that maybe this is too aggressive, and I think for the low risk pediatric thyroid cancer, which is localized just to one gland, we may refer from radioactive iodine, but this has not yet been agreed upon in the European recommendation. But I think in a future research, we'll have to show that for low-risk thyroid cancer, we may refrain from radioactive iodine. We may be over-treating the children currently.
Thank you.
Okay, one question.
Dr. Isra, pediatric specialist, Zulaikha Hospital, Dubai. Firstly, I would like to thank the speakers for this amazing session. My question is for Dr. Adalia. Regarding Graves' disease, what is the prognosis of complete remission? And is it high to the degree that we can counsel parents about complete remission within years of management?
Yes, so the question, if I heard it right, what is the rate of remission of Graves' disease? Now in kids, we have a high remission rate, especially for these kids who have low positive thyroid stimulating antibodies. They usually, the mean that we can control the disease is around 6 to 18 months. And usually these kids on follow-up, around 80% of them, they usually stay relapse-free if their antibodies, the stimulating antibodies, are in the low range. Yes.
I have a question to Dr. Santines, if that's okay. Can you hear me? Well, okay. With the era of severe obesity in children and the recent license of using liraglutide, the GLP-1, have you seen any cases with thyroid cancer so far with this cohort, in this cohort?
No, I haven't. So you mean the risk for thyroid cancer after using GLP-1?
Yes.
No, I haven't seen it.
The association with GLP. Yes,
Yeah,
the GLP-1 association with that.
I think it's there. It's too short to say anything about it. And in Holland, GLP-1 has not been given to children yet, except for extreme morbid obesity, but it's not been reimbursed yet by the health insurance companies. So I think that our numbers are still very low. Is this something that you've already encountered in your countries?
Well, we didn't see, actually. I didn't see myself, actually, but there is increasing use of this medication now in severe obesity patients.
Yes, yes.
Thank you.
Thank you all. We come to the end. I would like to thank all the speakers, and I'd like to thank my co-chair. I'd like also to thank you all. And tomorrow, inshallah, we will start at 2:30 sharp, beginning of the program. And you are all invited to have dinner with us at the restaurant in the lobby. Please come and join us immediately now after we leave. Have a good night.